A very good morning, good evening, wherever you are. And today I'm presenting the evaluation and management of an ophthalmic socket. I'm sure that all of you know what an ophthalmic socket is, but to get this case in the exam is a little challenging because most of us don't have the first-hand experience of dispensing ocular prosthesis. We're not doing enucleations, eviscerations, and putting in an implant frequently in our clinics. So it makes things a little difficult. Now, a very important thing is that last three FRCS exam centers, they had a case of anophthalmia. These patients usually don't have comorbidities. They don't have an active disease process which is going on, which makes it an ideal case to be kept in the exam. And I expect the upcoming centers to have a case of anophthalmia. So by definition, anophthalmos is the absence of eyeball in the socket, and a contracted socket is a one that cannot support processes effectively. The term effectively is very important here because there are different grades of contracted socket. Grade 1, grade 2, which is a mild contracted socket, might support the processes, but the cosmesis might not be as good as we want. So it has the contracted socket is the one which cannot support processes effectively. So what are the changes in the anophthalmic socket? So the basic understanding of an ophthalmic socket comes from our understanding that the blood supply of the whole of the socket after any procedure of enucleation, evisceration, or exenteration is affected. So we have an ophthalmic artery which is supplying the eyeball, and the drainage is by the vortex veins into the superior and inferior ophthalmic vein, and eventually into the cavernous sinus. So this cycle, this smooth flow of the blood is broken, which eventually leads on to the atrophy of the fat and the surrounding soft tissue, which causes this rearrangement in the orbit, eventually leading to contraction. So the blood supply is affected, and obviously there is a decreased mechanical support. We remove the eyeball, the muscle and fascia contracts, and also the implant we put in has some effect of gravity. So it tends to sink down, pull all the tissues down with it. And there is fat atrophy and reorientation of the orbital contents. In this blind diagram, you can see what we expect from an ideal socket. So the first thing is the volume replacement by the orbital implant. So an adequately sized orbital implant which will provide you volume. So as you don't have enough ophthalmos. The second thing is a smooth conjunctival surface so that we don't have any exposure of the implant. The third thing is the fornices. And the fourth is the prosthesis. So just to be clear, the orbital implant is the one which goes inside the orbit after enucleation or evisceration. And the prosthesis is the artificial eye. There are different types of processes and orbital implants I'm going to discuss. So as I've discussed, the ideal socket is the one which has an adequate orbital volume. It has deep cornices so that the processes can fit in adequately, and a very smooth conjunctival lining without any defects. So how would you examine a patient with an ocular prosthesis? So first thing is to look at the general facial appearance of the patient and symmetry of the face. When you comment if there's any gross difference in the orbital volume, if you see there's a clear cut or gross in ophthalmos, you comment on that. Then you move on to the examination. So then you examine the upper lid, the lower lid, and the superior sulcus deformity which is present. So upper lid examination would include your examination of the ptosis and lag ophthalmos, which is very common in an ophthalmic socket. The lower lid examination consists of measuring the eyelid laxity, which is measured by your distraction tests, and if there's any malposition, most commonly the entropy on which we see in an ophthalmic socket. So what if you have a patient who's wearing a customized ocular prosthesis? Your examination is incomplete until you have removed the prosthesis and examined the ocular surface. So the conjunctival surface gives you a lot of hints what is going on inside the orbit. So if you have a dry socket, you will have a dry fibrosed kind of look, and patient might have a discharge. If it is a wet socket, you will have a smooth, shiny conjunctival, well vascularized surface. The second thing is to measure the volume of the socket. If the patient is wearing a prosthetic eye which looks cosmetically fine, then you don't need to do anything, you don't need to do any investigations. You just have to polish the processes. But if the patient has grossly enough ophthalmos, then you have to assess the volume of the orbit, of the volume of the socket. So first thing is you comment on the relative depth of the prosthetic eye or the socket as compared to the other eye, and then you measure your furnaces on the slit lamp. So these are the different types of the orbital implants we have. You can see in pictures A and B, you can see that this is a very smooth surface without any indentations. So the materials are not important from the exam point of view. You just need to remember that there are two types of implants. First are the integrated, and the second one are the non-integrated. The integrated implants are made from different materials. They have small pores like this, just C to F. So these come in different shapes. Most commonly of them is hydroxyapatite implant, and which comes by the name of Forex. And the upper ones are the non-integrated ones, which are the PMMA and silicon. And there are different types of different variety of integrated implants known as quasi-integrated or semi-integrated implants. So these are basically the implants as seen in this picture, which are made from a non-integrated material, but they have some holes where you can attach the muscle and the tissues can go inside it. So these are the holes where you put in your sutures or the muscles when you are putting this in the orbit, and provides some sort of motility and stability to the implant and prevents its migration. Yeah, another important question I would say is the implant sizing. So there are different measures we take to size the implant. The ideal way is to replace 65 to 70% of the orbital volume to get a good cosmetic result. So the rule of thumb is if you have a child, you put in an implant which is 16 to 18 and if it's an adult patient, you put in an implant which is 20 to 22 And an objective way of doing this is to measure the axial length. So axial length measurement, reducing 2 millimeters from the axial length will give you some sort of idea what implant size you're looking at. And now coming on to some case scenarios of what we have learned and what you will do in the exam when you have a case of anophthalmia. So really the first thing we do is the general physical examination, and you can see this patient has a left anophthalmic socket. You can comment on the presence of conformer in the eye. There's a deep superior sulcus, which is associated with the anophthalmic socket. And you have some pre-tarsal show because of the ptosis, and this is due to lack of mechanical support. Okay. So, so these things, so the first thing I want to tell you is whenever you have a scenario, suppose if the examiner asks you, in case, what will you do for a deep superior sulcus? Don't ever jump onto the surgery. So the ideal way of measurement is first is observation, second is your medical management, which in this case is by the customized ocular processes, and third is the surgical management. So the ultimate aim is to delay or prevent surgery as much as possible. So there are different ways, which I'm going to discuss in the subsequent slides, of how we do that. So first you start with the history of the patient. Then you go on, do your facial examination, your palpation, your measurements, and then you discuss the management options. So yes, it is very important because uh, uh, the acquired causes of the anophthalmic socket has humor as one of a very important and a major cause. So in any patient, you have to think in terms of humor, which might be which might affect the life of the patient. So you don't have to miss any life-threatening condition. If you miss any life-threatening condition in the exam, it is surely going to affect your scores. So the anophthalmic socket can be congenital or acquired. But in acquired causes, the first thing I want you to remember is a tumor, then trauma, then an end-stage ocular disease like panophthalmitis or endophthalmitis with a complete conjunctivitis. Also, it is very important not just look at the eye which is being given to you in the exam, and use your common sense, like the age of the patient, what is the status of the other eye, and if you have any adnexal or any surgical scars which are present, which gives you any hint regarding what could be the etiology or the primary pathology for which the eye has been removed. So, for example, this is a very small child, be a year or so. So, when you see a child with an anophthalmic socket, the first thing you should which should ring a bell in your brain is retinoblastoma. So, when you are discussing this case, it is not about the anophthalmic socket. What they want to test you is your skills to manage this patient adequately and save life of this child. So if you don't mention your the screening of the other eye, the screening of siblings, genetic counseling, chemotherapy, the different aspects of retinoblastoma management, then your answer is incomplete regarding cosmesis, because in this patient you are not tested for the cosmetic part, but you are being tested for the life salvage of this patient. Just to the opposite of the previous case. In this case, what they would give you is history of congenital anophthalmia, and they want you to manage this patient. First, as we discussed, you have to look on the patient's inventories. Obviously, you can see that there is gross fullness of the one eyelid, and if you carefully look at the other eye has a follow. So this is not developmental anomaly in the right eye, which is basically a microphthalmia with cyst. So the management of this patient will be cosmetic, as well as you have to tell about the management of the other eye and the risk factors in the other eye, the associated syndromes. What about this patient? So see, you don't have to mention that there's heterophobia, that would be a disaster. So they want you to comment on the fitting of these processes and how you can improve this fit. So this I'm going to discuss in subsequent slides. And another different scenario which you could get in the exam is this, which sometimes patient can have an excellent prosthetic eye, so it is very difficult to judge, but you don't have to miss. Is my point of emphasis here, because uh, if you miss a prosthetic eye, it's just a, I would say, an earthquake really. So these are the different scenarios which I can think of when I think of an anophthalmic socket. First is the patient with a poorly fitting ocular processes like this one. And The management here is basically the management of the personal processes and the optical volume. The second is patient with a tricycle eye without ocular processes like this one. The third scenario which you can get is patient with an anophthalmic socket with associated complications where you might need some additional procedures with to correct the eyelids. And then the fourth scenario would be a patient with a contracted socket if they really want to test your advanced knowledge. The other thing is uh, after the advent of COVID-19 and a lot of patients getting mucormycosis in Southeast Asia, this is another scenario which might come up in your exam, and it's a good idea to just be well versed with different types of exentration procedures and the rehabilitative procedures for these patients. So in these patients that I discussed, first thing that the aim is cosmesis. Uh, uh, how, what basically they want you to what they want to know is whether what are the different management strategies that you have. So we discussed what are the changes in the anophthalmic socket, and now I'm discussing how they clinically present to. So obviously, because there's a lot of mechanical support and there's reorientation of tissues, you have your deep superior sulcus. There is ptosis, the correct ptosis, there's enophthalmic appearance, and there are lower and eyelid malpositions, either due to laxity or there is entropion, or if it's associated with the congenital cyst that I discussed, there might be some ectropion also. So just giving you a clinical case scenario, if you see this patient in the exam, so the first thing you're going to comment on is the facial symmetry and symmetry of the globe. If you comment on the Hirschberg test, the Hirschberg is not central, the primary position. And if there's no mass, you can comment on the lower face as well as the forehead. There are no adnexal scars. And then you measure the amount of ptosis this patient has, and do your the vertical palpebral height and MRD just to give you the amount of uh, uh, the difference in the eyelid position in both the eyes. Then you can comment on the condition of the ocular processes, whether it has scratches, what is the quality of ocular processes. So this is a little challenging because if you don't have first-hand experience with the ocular processes, you might not able to detect what is the condition. But it is worthwhile to mention if there are some scratches or what is the condition. If it is a grossly misfitting processes like this one, I think you'll be able to pick up that there's a color difference in the processes. The size of the pupil might be different. The size of the iris might be different. The color of the conjunctiva and the conjunctival blood vessels that they have drawn, they are different. So there are different aspects of ocular processes, but it is worthwhile to mention some of the differences like color, there are any scratches, or there is a gross size abnormality. Then eventually you can comment that you want to know the processes and evaluate the conjunctival surface, which probably they won't ask you to do. But they might question you regarding saying what do you want to look at, but they might not let you in processes. So how do you manage this case? So as I discussed, the surgical options are kept for the last. So the first thing that you do is if there's an enophthalmos, you provide convex glasses, and there's a very large eye, you can give concave glasses just to reduce the size difference. The second is if there's a severely decentered or severely enophthalmic prosthetic eye, then you have to remove the prosthetic eye and see the conjunctival surface and make sure that the conjunctiva covering implant is healthy. There are no gaps, there is no exposure of the implant. Then there are some pseudo measures to measure the orbital volume, which is provided by the implant. So sometimes what happens is that there is migration of the implant inferotemporally. because there's a lot of fat and the muscles are not able to, the inferior rectus and inferior oblique muscle, they're not able to support the processes. So the implant, because of gravity, tends to sink down and you have a decentered orbital implant, and which leads on to poorly fitting processes. So in that case, you might have to replace it with the new processes. But before doing that, because it's a surgical intervention, it's always a good idea to replace the ocular processes, because ocular processes is customized. You get the impression and try to put in a new implant. But because the orbital volume is less, your prosthetic eye is going to be heavier, because when you're going to replace most of your volume by prosthesis and not the orbital implant, your prosthesis tends to get very heavy and it does not fit very well in the formations. And if the patient, so there are a lot of aspects related to the prosthetic eye. You also have to assess the socioeconomic status. But I don't want you or expect you to comment, but this is just for the clinics that most of these patients, if they are from the lower socioeconomic status strata, I just give them a stock eye and ask them to get it polished every 6 months or so. So these are the different steps for the management of a poorly fitting of ocular prosthesis. So another scenario is when the patient has a tricycle eye and does not have an ocular prosthesis. So again, you go on to comment the facial symmetry, the amount of enophthalmos, the superior sulcus, and then you measure the ptosis. But the important thing here is if the eye is not as severely damaged as this one, then the first thing you have to comment on is the visual potential. So as it goes on, first you have to salvage the life, then salvage the globe, and then the vision. And final fourth step is to cosmetically rehabilitate the patient. So uh, directly jumping onto the cosmetic part is not ideal. So first you comment upon the visual potential of this eye, and you would like to assess uh, different things like the retina of this patient. You can get a B scan done, get a CT scan done, or the history and all that we discussed. And eventually the examiner will not lead on directly uh, what lines of treatment that he's going to test you. And when you do your measurements, examine on the slit lamp, they comment on the other eye, what was the initial injury, or what was the cause of the tricycle eye in this patient. So the management options in this patient, they consist of either removing this eye, doing an evisceration for this patient, or directly putting an ocular surface, or directly putting a prosthesis on the ocular surface. So what we do in these patients is test for the corneal sensations. If the sensations are gone, then you can directly put in a prosthetic eye, because when you put in a prosthetic eye, it might rub onto the corneal surface and lead to chronic irritation and corneal defects. So patient might not be comfortable. So a trial of ocular prosthesis without evisceration is ideal in this patient, and you monitor the ocular surface over time. And if the patient is not comfortable, the patient has chronic irritation, discharge, then you go on to do evisceration. And if not, so whenever you are uh, whenever you are asked about difference between evisceration and enucleation, always err in the side of evisceration. So protecting the sclera or sparing the sclera in any destructive procedure, it gives you a additional layer of protection from exposure of the implant. So it's always better to do uh, evisceration as compared to enucleation. But in some cases, which are mostly malignant cases, you have to do uh, radical surgery comparison to. Just in brief about some complications or associations of an anophthalmic socket, and deep superior sulcus is essentially part of an ophthalmic socket without the prosthetic eye because of the loss of volume. And
there is some posterior migration and reorientation of the contents of the orbit, which leads to a deep superior sulcus. And the management consists of first thing that we do is a trial of processes. We replace the existing processes with the larger sized processes. And even then, if the cosmetic result is not good, then you can go ahead and do a secondary implant and replace the orbital prosthesis or the orbital implant with a larger size orbital implant. And fornical shortening is a part of a contracted socket. And to prevent fornical shortening, there are some intraoperative measures like to do a minimal dissection in the fornices, attaching the extraocular muscles in their orientation to either an integrated implant or to do a myoconjunctival technique in the enucleation. And the conformer has to be in place for a longer duration of time to prevent for shortening because after doing enucleation and evisceration, if you don't put an conformer in place in the socket, your fornices are going to shrink. So the management consists of fornix formation sutures, if there are adequate fornices, if it's a mild contracted socket, and if it is a severely contracted socket wherein you can't fix any processes, then you have to put in a graft, essentially a mucous membrane graft, to provide some elongation in the fornices. And then the severely contracted socket, which has where there is shortening of the superior, inferior, medial, and lateral conjunctiva or the fornices, and it's a severely contracted socket. You can augment with the MMG or you can do a dermis fat graft. And the dermis fat graft can be harvested from any area of the body which has a lot of fatty tissue and usually taken from the gluteal area. The eyelid complications, the ptosis and entropia, if the patient has a say satisfactory fit of the prosthesis, there are no much complications in the orbit. The conjunctiva is totally covering the orbital implant. The volume is good, but the patient still has ptosis or entropion. You can go ahead and mainly do the ptosis surgery or entropion surgery in isolation as well. Now, this is something that I focus on in my clinics also, that cosmetic as well as functional aspect of an anophthalmic socket is very important because these patients have a lot of limitations in terms of daily routine activities like driving. They have some occasional restrictions and they have a low self-esteem and confidence, which you have to take care of as the physician. So adding into your answer really gives you an edge that you are providing a holistic care to your patients and not just treating them. So this was all in this presentation, and I am still trying to work on a comprehensive approach to the ophthalmic socket, not from the point of exam, but in general, how to clinically evaluate your cases and the decision making which goes into the management of an ophthalmic socket. So all the best for your exams. And if you have any questions, you can contact me anytime. Thank you so much.